Dr. Tom Hight, welcome to the Tick Bootcamp podcast.
Thank you.
Well, why don't you first share with us what brings you to ILADS?
I first came to ILADS a year ago, and I was seeing patients who were getting worse after COVID infections. My practice is a lipidology practice.
And what is that? What's lipidology?
Lipidology is the study of cholesterol, but my practice really is taking people who have high risk for heart attacks and strokes and reducing their risk. We can tell them when their risk is rapidly getting worse, or we can tell them when their risk is getting better. If the treatment program is working, the arteries are going to show it, and the risk will be reducing. So we were seeing something, though, after the pandemic where a phenomenon that was I'd never seen before. People were getting better, and then they would get worse. Sometimes they would continue to get worse. They were on stable protocols, stable medications. Nothing that we could find had been changed, but something was happening. And that's what led me to ask the question, well, could it be something weird, some sort of odd infection that increases inflammation in arteries? And that's when I started testing some of my patients for Lyme disease, and we started finding patients with Lyme disease. And I had not treated lots of Lyme disease before. I had treated some in primary care years ago, but that's what brought me here to learn more about how to treat these patients who have artery disease that's progressively getting worse and causing an increased risk for heart attacks, strokes, sudden cardiac death, and also for small vessel disease, which causes dementia and can sometimes cause an odd type of a heart attack. That's more common in women than in men, but small vessel disease and large vessel disease are affected by Lyme disease and these other tick-borne illnesses.
So your practice, it sounds like, is largely a practice built around treating people who are chronically ill, or you're treating people who are acutely ill?
You mean acute infections with Lyme?
No, just, I mean, their illness. Let's put Lyme. Let's put Lyme
Lyme
aside, because
aside.
before you started thinking Lyme, because I guess the question that popped into my head is, what caused you to think Lyme?
And that's different from the chronic versus acute.
Different questions. But so let's put the chronic and acute issue on the side for a second. We'll bookmark that, and we'll come back to the question I probably should have asked you first, which is, so you're observing a unique phenomena in your practice, and it begins to surface. It sounds like during the COVID window, but we get past COVID, and you're continuing to witness phenomena, and you're trying to come up with an
explanation.
Why
are these people getting worse? And they were getting better. Everything was working. We were treating. There were over 20 modifiable risk factors. It's not just about reducing cholesterol. It's not just about taking blood pressure medicines or stopping smoking. Those are sort of the traditional risk factors. But there are over 20 modifiable risk factors that have to be identified, hunted down, and neutralized in order to reverse artery disease. So once we get someone to the point where they're reversing their artery disease, we know their risk is decreasing if we see that sequentially. And so I was seeing people who were like that. They were getting better, and then all of a sudden the artery disease is getting worse. I didn't have another explanation. Looking at all the other standard modifiable risk factors, everything was being done by the books, and the other issues had been controlled.
So you have these patients who are presenting with an anomaly, and you're trying to come up with an answer for why that anomaly is presenting, and you come to Lyme. Bridge that gap for me. How does
the anomaly is artery disease getting worse,
right?
And people who have risk for heart attack, stroke, sudden death, dementia, risk that's increasing, progressively increasing, and it shouldn't be. And this is where the question about acute versus chronic, one of the acute issues that we see is people who have a heart attack and survive the heart attack.
Right.
And I see patients from, 7 or 8 or 10 or 12 states who've had a heart attack, and they kind of don't get better, or they don't know why they had the heart attack. The doctors can't explain it, or they just want to put them on a statin, and that's all.
And is that how you're distinguishing acute from chronic? Somebody who had an event and they've overcome
so an
it?
acute would be a patient who's had a recent event.
Okay.
And an event would be completely, an event that could take your life, but also increases your risk. So if a woman has a heart attack, her risk of being dead within a year is about 1 out of 4.
Wow.
If it's a man, it's about 1 out of 5.
Wow.
In 5 years, 1 out of 2 women are dead, 1 out of 3 men are dead. In 8 years, about 65-70% of women are dead, and 1 out of 2 men are dead in 8 years after the heart attack. And those are the statistics. And we have a 100% survival rate in our practice. And it's statistically significant for men at 1 year, 5 year, and 8 years. It's only statistically significant for women at 1 year. We don't have enough women heart attack victims who have stayed in our practice that long. So it's a very important thing to track down every risk factor, because in that first year, we could talk about risk within 2 to 3 months. Within the first 60 days after a heart attack, there's significant risk for another heart attack, and a lot of those deaths that occur within that first year occur within 2 or 3 months. So when I have a heart attack patient, I'm more aggressive about tracking down anything that's might be a chronic illness that we didn't know was a part of the process.
And you're now finding that Lyme is one of those chronic conditions that you need to determine if it is the factor that's causing the anomaly to occur when you're trying to manage these risk factors.
Yeah, so anything that causes stress to the endothelial cell. The endothelial cell is the inside lining of the arteries. And when that cell is stressed, we call it oxidative stress. Anything that contributes to that causes inflammation in the deeper layers. It calls forth inflammatory molecules and inflammatory cells, and they come in and they create cholesterol, and they bring in bad cholesterol, and they make the inflammation worse, and they cause plaque to get worse. And eventually, when the plaque gets worse to the degree that there's some gooey, soft plaque, we call vulnerable plaque. It's under a thin cap. It's usually a thicker cap, the surface of the endothelial cell. But when you have a thin cap, that thin cap means that it's possible to rupture that. And when you rupture it, it's like a little explosion, and it may not be lots of cholesterol that's in there that comes out, but the problem is that then your blood goes into that, and you got a laceration. It's a laceration on the inside of the artery, and what happens when you have a laceration? Your blood clotting mechanism kicks in, and it causes a blood clot, which blocks up the artery in the heart, and it can kill you, and you can die suddenly, or you could die later if you have another event. But it's certainly a dangerous event.
So let's identify the Lyme piece of this, because most of the folks in this podcast will have heard about Lyme carditis. And I'm not clear about whether or not the event that you're describing is Lyme in the heart itself, or is it the inflammatory process that's triggered by Lyme disease, perhaps in other organs, that's resulting in the anomaly that you're seeing in your patients?
Yeah, so that's a great distinction of different aspects of Lyme. I believe Lyme, the inflammatory downstream effects of Lyme, that it causes inflammation in the endothelial cells that make arterial inflammation worse. And I don't think it's Lyme. I think if you would do biopsy of people's arteries, you wouldn't find Lyme disease there, but you might find that, and this is theoretical, this study hasn't been done that I know of,
yes.
but you might find that the monocytes, the white blood cells, are carrying a piece of the Lyme molecule for the capsule or something like that. They're carrying a piece of it, and that causes it to be sticky when it touches the inside lining of the it sticks to the wall of the endothelium. That's what increases the inflammation. So again, that's theoretical. I've never seen that proven, but that's what I suspect is the connection between the Lyme disease and other areas of the body and the inflammation that happens in the arteries. Now, Lyme carditis is a different animal, and that may be related to actual Lyme disease in the muscle, but it might also be related to the same phenomenon, the inflammation that's caused on the inside lining, the endothelial cells on the inside lining of the heart muscle. Inflammation of the endothelial cells that line the heart muscle can cause inflammation of the heart muscle underneath. So if that happens, you can have scarring that develops, you can have dysfunction, and the heart muscle might not function as well as it used to. So the Lyme myocarditis, I'm treating several patients with that. But there are biomarkers that can tell us about Lyme myocarditis. One of them is the ultrasensitive troponin T test, which is a type of assay of troponin that's a lot more sensitive than the type of troponin that's used in the hospital. So if you go in the emergency room, you say you have chest pain, they're going to do a blood troponin test to find out if you've had a heart attack. Well, this test is a lot more sensitive, and so it can pick up much smaller events than a heart attack. It can pick up people who are having a heart attack or having myocardial ischemia, but it can also pick up myocarditis from viruses or from Lyme. Or Bartonella.
So one of the things that many folks in the Lyme community find frustrating is the specialization in the medical community of the American medical system. But I have to tell you that we've interviewed a number of specialists like you, and it's very powerful that someone like you, who's trained as a lipidologist, I never interviewed one before, has you're now giving us and the folks in this community some insight that I don't think anyone has ever shared with us, and the impact that this multisystemic infection could cause the challenges that you were describing just because of the inflammatory response, but also we could have an inflammatory response as a result of the bacteria in the heart, and of course Lyme carditis itself could cause a different presentation, and you are studying all three clinically. So where do you think the future is with the spread of Lyme disease, right? I mean, you're from Georgia, and you're certainly not going to have as many Lyme disease patients as the doctors have, for example, in my native Long Island in New York. But it is spreading, right? And we're seeing more and more ticks. We're seeing more and more Lyme disease, and I'd venture to guess that practitioners are going to see more and more of the presentations that you're now seeing as a result of the increased prevalence of Lyme disease. So where do you think this research is going to go, and what are your hopes for how you can contribute to helping folks in tick endemic communities to better treat their patients with these presentations?
That's a great question. It's multiple. It sounds like there's maybe 2 or 3 questions in there.
There are, and I apologize.
I think the most important thing that I would like to see is that that Lyme disease and other tick-borne illnesses can be seen as a risk factor for heart disease.
Okay.
A risk factor for heart attack, strokes, sudden death, and dementia, right? Because those are all arterial diseases. I would like to see more research done in biomarkers that can be developed that we can use to, for instance, if the white blood cells are carrying a piece of the Lyme, a genetic piece of the Lyme, the organism that's been killed, and they're presenting that to the inside of the artery, and it sticks there, and it causes inflammation to get worse. I'd like to see that test developed. I don't know if you're familiar with the long COVID test, that
Yes.
N-cell DX test,
Yes.
with the S1 immune panel. That's the spike protein attached to the monocyte. If we could have, and I know this would be difficult, but if we could have a piece of the Lyme particle that's attached to the monocyte that we could test, do the same test on, I think that would be really useful clinically. So
Me too.
we need better clinical tools, diagnostic tools. There's been a lot done in recent years with therapy. I think we need to broaden our definition of Lyme myocarditis, which is not that old. We just recently, relatively recently, we have Bartonella myocarditis, and we need to be able to use appropriate biomarkers to people who haven't had their heart attack yet. And if you've got Lyme disease, knowing that that's a risk factor, knowing that even with one risk factor, you should probably have your arteries checked. So there are heart calcium scans and there are arterial ultrasound tests that can tell us how much risk you carry. And so to not wait until the huge event happens and find out if you're going to survive your heart attack or not, but to take a more preemptive role so that we can come in and fix the problems before it causes an event.
With that, I really love this interview. This has been a fantastic and insightful conversation. I'd love to invite you to a more long-form interview so we can explore some of these things in more detail. But this is eye-opening in ways that you can't imagine. So I thank you for taking time to, first come to the ILADS conference and develop more tools for your patients, but also in addition to that, sitting down with us and sharing this. I think our listeners are going to be fascinated by the information you shared with us. Thank you very much.
You're welcome. Thank you.